Another point of caution that is very important that you have to remember that any patient with BMI more than 35 kilogram meter square, that is morbidly obese patient, we should offer them this Nissen Fundoplication very carefully, and I will say we should not refer them. We should not offer them Nissen Fundoplication at all. Hello everyone, welcome back to Dr. Strange MCH platform. So in today's video, we will talk about Nissen's fundoplication for a patient of GERD. In the first part, we will talk about the theoretical rationale, what are the indication of surgery in GERD, what are the do's and don'ts, how to work up a patient with GERD, and in the subsequent part, we will showcase a live surgery with Nissen's fundoplication. Please read the detailed disclaimer in description, and these videos are meant for education purpose only. And as a prequel to this video, please watch our previous video on gastric cancer surgery or the ruined by gastroenostomy, and also the different videos we uploaded about the suturing that includes mastering intracorporeal suturing to have a comprehensive understanding of the subject. And if you are new to our platform, please note that we have a dedicated app available that is for Android and iOS, or you can join the channel membership to have exclusive access to our premium content. The link for everything is given in the description of this video. So this was a case of 41-year-old female with severe erosive reflux disease with hiatal hernia grade 1 and GERD-induced asthma, and our plan was to do Nissen's fundoplication with suture chloroplastry. So let's start with the theoretical rationale. So friends, as all of you understand that the Nissen's fundoplication, this is a surgical procedure primarily indicated for the treatment of gastroesophageal reflux disease, abbreviated as GERD, GERD and hiatal hernias. In this video, we will focus more upon the GERD, its management, pathophysiology and do's and don'ts. So basically, there are 5 indications of Nissen's fundoplication in today's world. First will be GERD unresponsive to medical therapy. Primary management is PPI, as all of you know, or the complication arising from the GERD that can be severe esophagitis, stricture or Barrett's esophagus. And third will be hiatal hernia. In conjunction with hiatal hernia repair, Nissen fundoplication is indicated. Another indication can be patient prefer to have surgery over the long or lifelong treatment. Our patient is facing the adverse effect of medication. Or fifth indication will be extra esophageal manifestation that are symptoms of chronic cough, asthma, laryngitis that is attributed to GERD. So these are the 5 indications of Nissen fundoplication that you have to remember, and we will discuss it again in lengthy details. Briefly, these are the typical signs and symptoms of the GERD that can be heartburn. As all of us understand, there is a reflux of the gastric content in the esophagus that lead to the water rash or the heartburn, regurgitation, chest pain, or prolonged there can be dysphagia. Or there can be some atypical symptoms like nocturnal cough. Patient has a nocturnal regurgitation of these gastric content lead to sometimes they are on lifelong asthma treatment. There can be dental erosions, hoarseness because of laryngitis, or they can be diagnosed as a asthma. So first of all, let's clarify that most of these symptoms, if we have in today's world, we have very good medications like proton pump inhibitors or potassium channel inhibitors with domperidone. So these can be very well controlled. But problem with the medical management of early GERD is that available medication has not shown any ability to prevent development of Barrett's esophagus, that is abbreviated as BE. So Barrett's esophagus, as all of you know, is intestinal metaplasia, and it is a pre-malignant condition. Or the medical management has not shown that it induced regression of the microscopic intestinal metaplasia that develop at squamo-columnar junction and is precursor of visible BE. So medical management can control the symptoms, but it has minimal effect on the BE or its progression. And in contrast, a competent Nissen fundoplication, that is a properly done Nissen fundoplication, it will prevent Barrett's esophagus if performed before endoscopically visible BE develops, or a competent Nissen fundoplication can induce complete regression of microscopic intestinal metaplasia at SCJ, that is squamous-columnar junction, and avoids subsequent development of visible BE. So, as I said, in comparison to the medical management, a good Nissen fundoplication can halt the development of BE, and that is a very positive product of the surgery. So, if surgery is so good, then why not we offer surgery for every patient of GERD? Why patient are on lifelong treatment of this PPI? They are taking double dose, high dose. So there are some side effects of the Nissen fundoplication that can be dysphagia. They can have a difficulty in eating. There can be postprandial bloating or inability to burp or vomit. We will discuss it in more. And it significantly limited fundoplication use early in course of the GERD. So, as I said, when we wrap the lower end of the esophagus with this fundal wrap, patient is not able to vomit, he is not able to burp, and it is one of the very disabling side effect that patient has to live lifelong with that feeling that they have a say distension of the stomach, but they are not able to burp. So that limits the use, or we cannot recommend Nissen fundoplication to every patient with the GERD. And whenever you will discuss these issues with your medical gastroenterologist colleague, they will always give reference to this trial, that is the Lotus trial. It was a RCT which compared lap Nissen fundoplication to esomeprazole, and it showed no difference in the esophagitis or heartburn control between treatments. So when lifelong treatment say maybe up for 5 years, one group was on esomeprazole, another were offered lap Nissen fundoplication, and overall the esophagitis rate or heartburn control were similar between the two groups. So they will always discuss or emphasize this trial, but there is more to it, so I'll discuss it. So, as in all of my talk, I always try to give the important reference so that you can search the literature. So, as if you want, you can go through these reference, and you can have more knowledge of the subject. So, left hand fundoplication, it has shown to be effectively reduce all types of reflex. That is, there is not only the acid reflex, there is non-acid or bile reflex also, and it is most effective who have favorable response to PPI therapy prior to surgery and good compliance with the PPI therapy. And typical symptoms, objective evidence of acid reflux, esophageal and normal pH testing. That means patient who respond favorably to PPI therapy, who have good compliance to the PPI therapy, and has typical symptom of GERD, or there is objective evidence of acid reflux, that is esophagitis, or on pH monitoring, there is abnormal pH testing, they fare well, and they have better outcome with the Nissen fundoplication. So the primary indication of anti-reflux surgery for a GERD patient will be patient with esophageal or extraesophageal GERD symptom, responsive but not completely invaded by PPI. That means patient has some response or some relief with the PPI, but still they are having symptoms, or still they are having reflux. Number 2 will be patient with heartburn eliminated by PPI but continued volume reflux, that is regurgitation. As I said, the reflux is not only of the acid that we can control very well with the PPI, but if the lower esophageal sphincter is incompetent or lax, then the other content or the gastric content or the bile will keep on refluxing, and patient will have symptoms of regurgitation. Another indication will be patient is having well documented reflux events, preceding symptoms like chest pain, cough, or wheezing. As I said, these patients sometimes are on lifelong treatment for asthma, and later on they are diagnosed with the GERD. Or patient with GERD complication, that is sometimes they have peptic stricture or Barrett's esophagus or vocal cord injury while taking PPI twice daily. So that means having the maximum dose of the PPI, patient are still having the symptoms or the complication of the GERD. And another indication can be when patient is offered this choice of lifelong PPI or with domperidone or double dose, and they are comprehensive of the side effects, or they want one stop solution for their symptoms. Then the primary that can be the indication of the primary indication of the anti-reflux surgery. And remember, my friends, if patient is having very well controlled their symptom with the single or double dose PPI, or it's a uncomplicated GERD. I mean, there are no other issues like laryngitis or hoarseness or nocturnal asthma, wheezing, chest pain, then the anti-reflux surgery Nissen should not be offered to these patients unless patient is having a very strong concern for the lifelong use of the PPI and their side effects. And on the contrary, this is a repetition of my talk that patient is having severe GERD, symptoms not controlled by medical therapy, then he becomes a candidate for the surgery, or patient not having a concern for the basically lifelong use of the PPI, their side effects, or there is a complicated GERD in the form of Barrett's or refractory esophagitis or stricture, then these patients should be considered for or should be offered the this Nissen Fundoplication. There will be some overlap, some repetition of my talk as we gather our information from the various sources, but I feel the repetition is good for your learning. Another very important or puzzling, issue in the mind of trainees or the budding surgeon is what to do in a case of esophageal motility disorder. So patient is having esophageal motility and he is also having the GERD. So how should we proceed in this patient? So significant esophageal motility issue may not be ideal candidate for a complete, that is 360-degree Nissen fundoplication. There is a risk of post-op dysphagia, and partial fundoplication technique like toupee or door may be considered in these patients. But again, I'll come over on this issue again. We'll discuss because I have highlighted the may. So partial fundoplication technique may be considered, and we will discuss more about this. Another point of caution that is very important that you have to remember that any patient with BMI more than 35 kilogram meter square, that is morbidly obese patient, we should offer them this Nissen fundoplication very very carefully, and I will say we should not refer them. We should not offer them Nissen fundoplication at all, because their chances of failure of the Nissen fundoplication in these patients are very very high, and alternative surgery option in the form of some bariatric procedure or gastric bypass may be more appropriate. So before offering Nissen fundoplication, always be very very cautious in a morbidly obese patients. And friends, do remember that careful patient selection is very crucial to optimize outcome and minimize post-op complication. Otherwise, you will have a post-op patient who is not able to burp, not able to vomit, and or there may be failure of the Nissens in morbidly obese. So you will have a cribbing patient who will be always complaining that whether this surgery was indicated or not. So if the patient having very good control of symptom, or there is some concern of the esophageal motility, or patient is morbidly obese, then you should think or rethink about offering the surgery to that patient. So here is that contribute with a reference that it does not appear that patient with ineffective esophageal motility, that is IEM, has higher risk for development of new onset dysphagia after Nissen that patient with normal esophageal motility preoperatively. Having said so means, previously we said that if patient is having ineffective esophageal motility, then we should not offer this 360-degree fundal wrap, that is Nissen fundoplication, and partial wrap may be considered. But as the evidence is emerging, so it is said that the complete wrap, that is Nissen fundoplication, may be offered for these patients also. So let's discuss about the GERD pathophysiology briefly. So friends, all of us understand that a single most important factor in development of GERD is incompetent lower esophageal sphincter, that's incompetent LES. There is a progressive dilatation plus deterioration of the gastroesophageal flap valve mechanism result in the loss of anatomical anti-reflux barrier and allows for the acid and bile to reflux from the high pressure zone of stomach to the esophagus. So that is the basic pathophysiology. There is an incompetent LES. So basically there are 4 stages of GERD that you have to remember. One is non-erosive reflux disease. There are only symptoms. There is no Barrett's, or there is nothing like precursor of the BE. There can be erosive reflux disease. Erosive reflux disease, patient is having some precursor of the maybe metaplasia, or there is some something as chemical injection, but these symptoms can be controlled, or these signs can be controlled with the use of PPI. Severe ERD will be when these things cannot be controlled with the PPI use, or there is a visible barred esophagus, there is a visible this intestinal metaplasia. So these are the basically 4 stages that you have to remember for the GERD. So friends, basically there are 2 fundamental determinants of the GERD. First is status of the LES, whether it is competent or non-competent. What is the mechanism, what is the pressure, what is the length of the esophagus, and composition of the gastric juices refluxed into the esophagus. So whether it is the acid only, it's a bile or mixed. Of the two mechanism, status of the LES, that is the primary determinant how the patient will progress further in life. So, as the common denominator of the GERD will be disappearance of the force that maintain the gradient between the stomach and esophagus, and when this occurs, the resistance to flow of gastric juice from the high pressure stomach to lower pressure esophagus is lost, and in the early stages this loss is transient, so patient will have symptoms off and on, but in advanced disease loss of force is permanent and patient is having constant reflux of the gastric content into the esophagus. For preventing the reflux, there are 2 mechanisms. One is the normal lower esophageal sphincter pressure, and second is the length of the abdominal esophagus. So both should be competent, both should be normal, and the normal LES pressure can be nullified by the short overall LES length, and the normal LES length, lower esophageal sphincter length or the abdominal esophagus length, can be nullified by the lower esophageal pressure. So both the pressure of the lower esophageal sphincter and the length of the esophageal sphincter or the abdominal esophagus should be normal to prevent the reflux, and that is the whole conundrum of this mechanism. And in the situation where the length of the abdominal esophagus becomes permanently inadequate because of the constant reflux, there can be stitching, there can be scarring. The abdominal esophagus cannot collapse in response to challenges of the intra-abdominal pressure, and that leads to the permanent failure of the LES. And again, as I said, problem with medical management of early GERD is that the available medication, whether it is the most competent PPIs, has not shown any ability to prevent development of the Barrett's, that is BE, or it induce regression of microscopic intestinal metaplasia that develops at the squamocolumnar junction, that is precursor of the visible BE. So again, I'm re-emphasizing that in a progressive GERD patient, the medication are only symptomatic and they are not halting the progression of the disease or development of the BE. So whenever you are evaluating such patient, a preoperative endoscopy and endoscopic manometry study, that is esophagogastroduodenoscopy and endoscopic manometry study EMS, are must to evaluate these patients. And EMS, why? Because that will detect the esophageal motility disorder that may lead to troublesome post-op dysphagia, and accordingly you can plan. So, as I said, it's a dogma or the common belief that patient with ineffective esophageal motility, that is a mean distal peristaltic amplitude of less than 30 mm of mercury, or there is more than 20% loss of peristalsis, these patients should undergo partial fundoplication to prevent post-op dysphagia. So that is the common belief or common notion. But the recent studies and the literature, the link for one of the study I have given here, has shown that post-op dysphagia after Nissen's is no greater with IEM than with normal esophagus motility. That means even if we do Nissen Fundoplication complete wrap for a patient with ineffective esophageal motility, the rate of post-operative dysphagia vis-a-vis complete wrap, that is 360, or partial wrap is similar. And for a patient with Barrett's esophagus, that is VE, in the preoperative evaluation, these patients with BE, high-grade dysplasia or adenocarcinoma, they should be treated with mucosal ablation or resection. Like if high-grade dysplasia or BE, then they should undergo mucosal ablation or if adenocarcinoma resection, and otherwise straightforward fundoplication should not be offered. For a severe structure not responsive to dilatation therapy, that is 16 mm is not achieved, they should also be offered esophageal resection. For a low-grade dysplasia, they should be treated with high-dose PPI for 3 months. Then they should undergo repeat biopsy. Fundoplication should only be considered for these patients of low-grade dysplasia if the subsequent pathology shows no progression to high-grade dysplasia or carcinoma. So for low-grade, you should consider PPA therapy. For high-grade and for adenocarcinoma, they should be offered the ablative therapy or the esophageal resection. Another point of caution for all of you is that patient with history of gastric surgery, GERD with previous gastric surgery, they should be approached very carefully, because GERD after gastric bypass, partial or sleeve gastrectomy and vertical banded gastroplasty, these patients cannot be treated by fundoplication because fundus is anatomically disrupted by the prior surgery. So always keep this point in your mind. With that, friends, we have reached the end of this theoretical rationale, and now in the subsequent part of this video, we will showcase the live surgery, that will be how to mobilize the esophagus, how to do the chlorplasty, how to do the fundal wrap. That will be a complete video of approximately 50 or 60 minutes. So stay tuned. And as I said, you can download our app available for Android and iOS for exclusive access to the premium SD content, or join the channel membership. The link for everything is given in description of this video. So thank you very much, friends. I hope I was able to add some new insight. Now you can understand the pathophysiology of GERD better. You can choose your patients and offer them the appropriate surgery in a better way, in a more informed way. So stay tuned, and if you're watching this video on our YouTube channel, do like the content, share with your friends, and hit that bell icon for all the future updates. Thank you very much. Happy learning.